region. There may be an increased sacral sulcus. This is one of the muscle energy sort of points. So we'll do a muscle energy sort of anatomical survey, just a little exercise in anatomy. If we haven't measured Baer's point, and Cliff Fowler made this point because he often stretches the iliacus in this position, that you can sort of get more relaxation, generally speaking, with the patient prone while you palpate in and push into the abdomen than when they're supine. Or if we haven't done passive movements at this stage, which we did in supine lying by sort of coming here and feeling, we can lay the patient in prone and do a medial and lateral rotation of the hip to the end range and feel the sacroiliac motion in that way. That's an alternative position to side lying and to supine lying. If we've already done it, we wouldn't do it here. Now then, here are some accessory movements from the Norwegian system. The crosses represent the pressures. So what I'm doing is pressing on the apex of the sacrum and on the posterior superior anterior spine here, posterior superior spine here. So I'm effectively producing an anterior iliac rotation. On this side, I'm rotating the ilia posteriorly, pushing the base of the sacrum forward. This is producing a posterior iliac movement. In this case here, I'm picking up the inferior lateral angle of the sacrum and pushing upwards, and I'm on the ilia and pushing downwards. This would be the correction of an upslip, or the aggravation of a downslip, if we're using it as a provocative test. And this one here, where I push on the ischial tuberosity and the base of the sacrum, is a way of producing an upslip or correcting a downslip. It would become a technique. So that's accessory motions that we're testing there. And lastly, we can do provocative movements, which are really like taking it into what you consider to be the corrective position or the opposite to the corrective position, and just seeing if it hurts a little bit more or if it relieves it. So those are the ways of looking at muscle energy as far as an examination is concerned. So we need to kind of do that as a little thing, like a plan, a protocol. Before we do that, though, I would like to go back to this. Before lunch. I think you've probably done enough of this at the moment, so we can Isn't that a good idea? Once again, the use of Post-it notes. Isn't that good? Yeah. Very good. Okay. Can you all see this? And I'll bring it up there to the table so we can look at it. I'd like to look at the posterior part of the buttocks here, because a lot of these palpatory points are going to be part of the muscle energy analysis, but they also fit in very much with various points on the manual therapy analysis in terms of where things are. So just as a little exercise before lunch, when you kind of probably don't want to take too much more stuff in, let's look at this and think where we are. Now, can I just go over this with the spine and with this little diagram, and then we'll bring, actually I'll bring the diagram down so it's not quite so far away from you. I found this to be incredibly useful, this little set of anatomical surface marking points. All right? We're going to find a number of things, and we'll relate everything to these one or two bony points. One is the iliac crest. One will be the posterior superior iliac spines. Now then, in most people, and I realize that there are differences here, if we draw a line across the posterior superior iliac spines, it goes through S2. If we draw a line across the iliac crest from one side to the other, it goes generally through the disc space of L4, L5. Now then, having found the posterior superiliac spine and S2, we need to find L5 spinous process. Very important spot. Now then, if we draw a line between the posterior superiliac spine and the spinous process of L5, exactly halfway along that line, we will find the zygapophyseal joints. So if we've got to give them ultrasound, or if we've got to give them laser or something like that, we know exactly where they are. Now then, if we've found one set of these, all we need to do now to find the next set is to find the interspinous process space, in other words, the space between the vertebra here and along that line, and where that space is will be the next zygapophyseal joint. So we can find exactly the anatomical location of those joints. So that line going between posterior superiliac spines, posterior or the spinous process of L5, halfway along it, if we bisect it, it'll give us that facet joint line. Now then, if we run a line upwards from L5 just parallel to the median line of the body, we will find more or less where the transverse processes are. And the transverse processes are going to be higher than the spinous processes because, of course, they're arising from the pedicles. So they're going to be almost in the interspinous spaces as well. And we should look at a spine and just confirm that thing. So we're just looking for these tips as we come up here. So we need to sort of find these. And if you just draw a line up, you can see that it more or less goes through the tips of these things here. Now L5 is a devil to feel. It's forward. It's got this mass of the erector spinae aponeurosis over it. And I think it's very difficult to feel altogether. I think that thinking about these various bits of the iliolumbar ligament, to me, other than giving ultrasound or laser, they are not really accessible to things like deep transverse frictions. I think if we're doing frictions through the massive tissue here, what we're probably doing is frictioning the thoracolumbar fascia or the erector spinae aponeurosis. I don't think we can get down deep enough, but we've got to sort of think that these are points we're trying to feel with muscle energy. So we better know where they are before we start saying, oh yes, that's more rotated on this side than it is on the other side, because that's what we're basing our evaluations on. And it's a difficult area. So how do we feel this? What we're going to do is to know more or less where the spinous process is, know that the transverse process will be just a little higher at L5 than the spinous process, and then we can come along the iliac crest here, and where it starts to descend, at that point we're going to start pressing down. And watch the end feel through this tissue. Does it feel that there's some kind of hard stop as I press through this tissue? If we do, that's probably where the transverse process is. And we can come up a bit and see if it gives a bit, down a bit and see if it's much harder. Okay? So that's the anatomy area of that spot. Now I'd like to come down to the lower part of the sacrum. In manual therapy we didn't spend much time on this, but now with muscle energy we realize that was an inadequacy in our system. This is a key spot here, the inferior lateral angle. Okay, and it's this spot here, that's the inferior lateral angle. And how do you find it? You find the sacral cornu, which is this, which is the arch over the sacral hiatus, and you come downwards and outwards until you find the lateral lower point of the sacrum. And what we're going to be trying to find is it tilted like this one side to the other, or does it appear to be more caudal or more cranial? Based on this is going to be what we say has happened to the sacrum very often. And we're looking diametrically opposite to this along this oblique axis to this area here, just on the inside edge of the posterior superior iliac spine. That is called the sacral sulcus. So we'll be feeling down here, 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 and that side there. Next thing we'll feel is the ischial tuberosities here. Then I want you to look at this, because we want to feel the sacrotuberous ligaments. And that's going to lie, if we've got the sacrum here, we've got the ischial tuberosities here like this, the plane that we'll find is between here. We're not palpating down here somewhere in the perineal fascia. We're palpating between that and that on that plane. And because the thing is like a crescent-shaped thing coming out like this, we're going to just wrap our thumbs around and push upwards and inwards. This should be one of these tenderish spots, but not intolerable spots. And we need to push in, and we need to sort of see if there is any difference in the tension from one side or the other. Because, of course, if the ilium is posterior or anteriorly rotated, there's going to be a difference in tension, one side to the other. If we've got an upslip, there's going to be a difference in tension. These are things that we will be looking for. So that's what we should do from the back, and then when we've done that, we'll come to the front and we'll just palpate. We'll leave that till we've all been to the toilet after lunch, so we don't keep losing people who've got to go and empty the bladder. Okay?
So where's the sulcus in relationship to the Z joint of L5?
It's just below it. Yeah. Well, yeah. We're drawing a line up through here. And I mean, if you look at the spine, you can kind of see this reasonably well. I should just come round posterior superior expand and just go down there. All of these things, you know, are not going to be accurate to probably half a centimetre, and this is what's the problem. You know, in this study, I think if we ever sort of decide to do a little study amongst us, what we can find, I think the first thing to do is to spend 10 minutes on not what we expect to find, but where we're feeling. Do we feel here, or do we get under here and push up? That would seem to be less likely to give us variations than if we some spot here or down like that. So we start here and work up till we come just below that joint. In some of the osteopathic circles, and certainly what Kirkcaldy Willis, they used to kind of look at the superior part of the sacroiliac joint through this, and then the inferior part, so they had a double kinetic test. Well, this, you know, is getting quite far forward, and so I don't know. Is it possible to move the top part of the joint, not the bottom? Oh, you know, it's getting into a real difficult sort of business here if we start talking in these terms. So I usually just look at where this is. This is a little bit behind the joint, so presumably we get an amplified effect of a very small movement when we do this, if we're fairly far behind it, because that's the lever system. Down here, it's much closer, so it'll be relatively much less movement down there. And I find it very difficult to think that this could move and that couldn't move. So, shall we do a little bit of palpation? Or do you want to go to lunch first? What would you think? Here we are. Look at what a democratic instructor I am. But you can't make your minds up. No, or the giant within? No. I looked at the picture in the front and I thought, well, it's already within. So, what are you going to do? Lunch, all right? Kathy has decided. Lunch. She's read the book. Very well.
Don't worry, Rob. Tape's going to put angle on it.
So, what we're going to look at now is to look at the diagrams on the board here and try and place ourselves on these various structures. If we can find posterior superiliac spines, we can find the spinous process of L5, we can draw a line between them along that line, as we can see, and I needn't repeat it all. That's where we would find the zygapophyseal joint. So, as far as the sulcus is concerned, I want you to make sure that you know that we're not necessarily feeling a kind of a big dip or anything. Sometimes it's a matter of tensions, and we're going to sort of go over the posterior superiliac spine and then press in and see if both fingers go in about the same amount. Now, if we've got dysfunction, we're probably going to have tissue texture abnormalities in this area, which might, I'm not saying we're analyzing them in detail, but might give us a difference in feel from one side to the other. Now, as far as the transverse processes are concerned, because when we deal with muscle energy, it's sort of an integral part of that analysis, it's really important to try and palpate where these things are. So come on the iliac crest, run across from there and see if it's reasonable that that should be the space between L4 and L5. Just occasionally we have a very high riding L5 as opposed to a very low riding L5, and sometimes you've got to sort of palpate across and you think, geez, that doesn't feel reasonable in terms of where the iliac crest is. In those circumstances it may well be that we've got an abnormality of position of lying between the ilia here in the pelvis. So all of palpation is fraught with chances of misrepresentation of what you're finding, and so we have to try and do this as anatomically as clearly as we can. So be able to find the interspaces, of course I know you all can, between the spinous processes, and if we're running up that line there, that would be where we would find the zygapophyseal joints of each of the individual segments. When we come to the inferior part of the sacrum, find the sacral cornu, which you can usually put your fingers around. Come from the coccyx, then come up until you can find the sacral hiatus. This is where Dr. Cyriax used to use his epidurals. Into that area there, then we'll go on a 45-degree line out and just feel for that inferior lateral angle. Come further out and feel on the softer tissue, and then work back until you feel you're definitely on to bone. Then see if you can feel that it's coming, and like that, as the sacrum flares inwards towards the coccyx. So this is a sort of an important area. The other thing that I would sort of mention in this area is that if we come into the posterior superior iliac spine, and if you've got any problems with this or any of these palpations, don't be embarrassed to say, because we all have had difficulties with some of these at some time. And if you come to the posterior suprailiac spine and just sort of lightly sort of think of a line down, and then where the inferior lateral angle is, now here we've got the line of the sacrum. So as we come across the sacrum here, we'll feel bone, and then it doesn't feel quite bone, but it doesn't feel very soft either. That could be the upper continuation of the sacrotuberous ligament. Now, if we come further out, you'll feel definitely on soft tissue as we go through gluteus maximus. And then if we think about, all right, here is the trochanter, I've come off this, so what I'm probably over here is the piriformis. Can I confirm the piriformis by making the patient do a little lateral rotation movement? So can you push your heel in towards me, and I can sort of feel I'm pushed out, let it go, and push again towards me. Yeah, and let it go, and push again towards me, and let it go. And I can feel gluteus maximus is not particularly tightening in that regard. So by looking at bony points and thinking where you are and confirming where you are by coming back, you can go soft, soft, harder, bone. Okay, now let me come off, and I can feel there's a difference between the bone and this tissue here. And this is the kind of feel we'll get if we come now into the sacrotuberous ligament. I've got this here, I've got the sacrum there, so it's on a plane between these, and so I'm going to come up here and push, and it should be tough tissue that I'm feeling here. These are massive big ligaments, like as thick as your thumb, and we can kind of push and feel that tension there that won't allow me to go in. So these are a lot of this is related to findings in muscle energy, and certainly confirmatory energy or confirmatory information in manual therapy. And so it's really important that we get these palpation exercises under control. So if you've done it all before, you can be quick. If you haven't done it before particularly, then make this an important thing for 20 minutes or so. Any questions? Plenty of instructors around, so you should be able to get enough help.
Just show where the sets are again. I still, even from your picture,
Yes. Let's just think for a moment about the passive movement of the joint. We'll kind of jump around a little bit in terms of a palpatory analysis, and then we can kind of put it all together just to run through everything when we've kind of done all these little bits and pieces. Okay, so a palpatory analysis, what I'm suggesting to you is that there are a variety of ways that we can do this. Okay, and I'll jump between the left and the right side just in terms of appropriateness for the camera here. But if I were going to look at the left sacroiliac joint in the supine position here, I would gently place my hands in the sulcus posteriorly, and I'd take the leg into a flexed position and across and just move the leg sort of across and up, and I would just feel the motion of the ilia in a variety of ways. And I'm not trying to sort of work out exactly like you might for an extending joint on a convex surface, does it go forward and all that. I'm just really feeling, is there some give in the back of the joint when I move this? This is one way of doing it. Another way that I find to be quite helpful is to get the patient inside lying. Are you comfortable there? Yeah. Okay, and we can come into this position here and get hold of the ilia and just move the ilia like this. Now, there are two ways of doing this. I use this a lot as a mobilizing technique, but of course I've got no power to do it in this position. The technique, same joint for mobilizing, would be to get onto the bed like this, let the patient lean against me and just move like this. Now, this is not a bad way of doing it as a movement, particularly if you've got small hands and a big patient. You can sort of do this quite well by going into the mobilizing position and doing it a little less. The other position for doing this is in the prone, and I'm not saying you do it in all three positions, you do it in one or the other, whichever you prefer. To come into the sulcus again like this, patient in prone lying, and just take the leg into medial and lateral rotation. So the ilia is following like this to give you this feeling of resilience when you use these passive movements of the joint. Now then, there seems to be a little bit of a controversy about testing the accessory ligaments. What I always learned and always felt comfortable with was this, and so either my results have been kind of producing erroneous findings, but to get the sacrotuberous ligament, I would bring the hip of that side to the same shoulder coming up here, so that the hip's coming up here and it's bringing the ischial tuberosity with it like that, which is taking the ischial tuberosity away from the sacrum. To get the sacrospinous ligament, which is coming across in this level, I would take the hip to the opposite shoulder. So same shoulder sacrotuberous, opposite shoulder sacrospinous, and then to carry the leg across here, which would be to test the posterior sacroiliac and the interosseous ligaments, as that's pulling the whole, flaring the whole back of the joint posteriorly. So it's kind of doing that a little bit for sacrospinous, doing that for the posterior sacroiliac ligaments. And of course, this is a matter of holding it for a 20-second period or whatever. If a patient has got some complaints that seem like the dull, diffuse, ill-defined aching of a ligamentous laxity, which should go in with sort of more movement when we've done these passive movement tests and so on. So there are those movements here. Now, just in conclusion of this little bit of the situation, if we come into a position here, you'll see, if you follow the little diagrams of Olaf Evjenth, which are really very good, he has a sacral stress test which he does, which is to put the hand into the sacral sulcus here and just push the bone forward on one side like this. Oh, just, yeah, okay. I knew there was something else. How do we check the iliolumbar ligament? This has brought the whole thing back, because this is one test of doing it, and I think that's probably what we're testing. If we do it from the top here and we come onto the transverse process and try and take it forward. Now we can exaggerate the effect of the transverse process going forward. In other words, producing a left rotation by pushing transverse process on the right forward. I can make this whole situation more complete by hooking my hands around the anterior part of the ilium here, going into where that transverse process that we found and trying to sort of increase the tension here on this side. Now then, this is taking this forward. I was kind of impressed with one of the fellows in the Netherlands who'd got these multiple tests all worked out for this. I don't know how valid they were, but at least he'd thought about how do I differentially tighten up various ligaments in this area. And he'd got the sort of thing of coming into this for the posterior ones, which would seem quite well. And then he pulled a little bit more like this for this lateral one. Okay, and then he took the whole thing away and down for what he said was the anterior ones. And when he was doing the anterior ones, he was holding the spinous processes back like this, so he was keeping this transverse process back as far as he could and pulling down like this. Now, okay, say we know that hurts. What are we going to do about it? I don't know. I haven't got a clue. You know, the only one I think we could reasonably get at, or two that we could reasonably get at, would be the posterior directed fibers and perhaps the lateral ones. And even then, I'm not sure that we can do things like transverse frictions, as I've said, because if you look at the anatomy, now I was going to bring some of Bogduck's tapes, but they take a bit of a long time to go through here. We've got this huge mass. I mean, they're going and they're pulling stuff out like this and laying it out, and it's a mass of tissue, and we're thinking we can get down onto a ligament. It's hard enough doing a ligament like the medial collateral ligament in the knee, you're kind of working, but if you thought you were having to do it through this thickness, sometimes I think we're stretching credulity in what we say we can do. So for me, if I get one of these and I think, well, I try to do some fairly high energy ultrasound, as much as they can stand with continuous current, just sort of coming over this area and hope that it gets through all of this. Usually they can tolerate this because the soft tissues are not reflecting the beam and it's going down. But, as I say, this would be the way, certainly for testing those important posterior fibers. I don't know how important the anterior fibers are with all this. Presumably they're important, else they wouldn't be there. We develop them as a consequence of an aging process, so presumably they're quite important. But certainly I think these posterior and the lateral seem to fulfill a very important role of controlling anterior shear of the L5. So it must be quite important from that point of view. But that would be how we would test these. So we've got the whole of the accessory ligament mechanism under control as far as a testing procedure should be. Now then, the last thing would be those, and you see it in the book, and you can kind of look them up as we go so that we can kind of proceed here a bit, which is to have a look at 3 or 4 things. The first thing that you will see is done is, and this is like going to be a mobilizing procedure as well, we take the apex of the sacrum like that, the posterior superior iliac spine like this, and we're just going to move it in that direction. So this is exaggerating an anterior rotation, or it's correcting a posterior rotation. Now sometimes it depends on the chronicity of the problem. If it's an acute-ish problem, recent, okay, recent would be a better word than acute, it would tend to be alleviated if you pushed it into its corrected position. Sometimes if it's a chronic problem, it likes to stay where it is, and you sort of start to push it forwards and say it's in posterior rotation, and you know that's the direction that